Request Ms. Asha Murli to be on stage, please, to honor our next speaker. Our next speaker is Ms. Deepti Gaur Mukerjee. She is the Chief Executive Officer of the National Health Authority of India. Can I request ma'am to be on stage? Ms. Deepti Gaur Mukerjee, she's a 1993 batch IS officer of MP cadre. She's been Additional Secretary, Ministry of Health, Family and Welfare. Thank you, Asha. Ma'am, request you to please. The topic of the next session is bridging the health insurance gap. Health insurance is an area where the government of India is working a lot, and so are the insurance companies. And to chair the session, can I please invite Mr. Sunil Sharma, the Chief Executive Officer of RGA. Can I ask Sunil to please proceed with the session?
Good morning, everybody. I think we're really honored to have Madam here to share, some of the biggest health, kind of services that we've been doing in the country. I think we always used to talk about, we do not have the social security in the country, but many of you would have seen the initiatives the government has taken in terms of providing the health services to the most vulnerable society of India. I'll give you some number later on, but to begin with, I will request Madam to please address the audience and share some of the, the progress that this scheme has been making in the country.
Good morning, ladies and gentlemen. I see very few ladies, but I'm happy to see them nevertheless. I would like to thank the Institute of Actuaries for inviting me here. And I'm very excited to be here because it's my first interaction with the people who say no to everything. Right? So you're like the finance people of, the government or of a company. The first thing you'll say is, what is it for us? How much money will we lose? Right? So it's very interesting to be here because I'm representing an organization which is championing the cause of the poorest and the most vulnerable. I've been asked to speak to you about how government is bridging the health insurance gap for the bottom 40% who is our target of the population of India. So I'll be talking to you about the Pradhan Mantri Jan Arogya Yojana. It's under the I don't know how many of you have heard of the Ayushman Bharat umbrella. So I'll start with that, and I'll set a bit of the context of how we are fitting into the universal health coverage piece. Then I'll talk to you about the salient features of the scheme. What are the important features which affect your industry? And then let's see how we can look at some kind of a collaborative effort so that you and us both strive to give services to the ones who need it the most. So Ayushman Bharat is an umbrella. 2018, it was launched by the Honorable Prime Minister. It initially had two important pillars. One pillar was to do with the primary and the preventive health care, where we are looking at giving preventive health care through health and wellness centers, which are now called Ayushman Arogya Mandirs, across the entire country. So basically, these are small health centers and health and wellness centers at the cluster of villages or in small urban clusters, essentially in urban poor settlements. And the other pillar was our scheme, which is the Pradhan Mantri Jan Arogya Yojana, where we provide health cover for the bottom 40% of the population for secondary and tertiary care. It's a completely cashless scheme, and it's completely free to the individuals. Now, who are these individuals I'll tell you later. After COVID hit, the two more schemes were added into this umbrella. One was the Ayushman Bharat Health Infrastructure Mission, in which a lot of money is going into building physical and social infrastructure. And the other part is also which I handle, that means my organization handles, which is the National Health Authority. Most of you may be getting confused with NHA. When I say NHA, people say, ha, NHA, that they think it's the National Highways Authority. So the only difference is, yes, we are also highways, but we are building digital highways. So I look after the fourth pillar, which is the Ayushman Bharat Digital Mission. I'll talk a little bit about that because, like I said, we are building the digital highway. Where does Ayushman, for the ease of speaking, I'll call it Ayushman Yojana. I think it'll be easier for all of us, especially me because I can't keep on repeating PMJY, PMJY. So Ayushman Yojana, where does it fit into the piece? We all know about universal health coverage. We know about the 3 dimensions of the WHO cube in terms of, who is covered, what services are covered, and what proportion of costs are covered. We also realize that the insurance market, by its very nature, only caters to the people who can afford to pay for it. In India, I think the penetration of coverage has been is very low. So ultimately, the people who need it the most get left out, right? So by bridging this gap, by covering this bottom 40% of our population, which is almost 12 crore families, which amounts to about 55 crore people, right? For those who don't understand crores, it's about 550 million, right? These people, we are covering them. So we're trying to bridge this health insurance gap. Let me tell you, it is the world's largest publicly funded health insurance scheme. And we all know that in the Western countries and maybe in the East Asian countries, whenever you have health insurance, it's a mixture. Either it is people pay for it, or there is public funding of it through taxation or through some other purposes, right? So some in the US, it's completely private. In other areas, it's a mixture. But in a country like India's, I think where the market has not really thought about or has thought about but not come up with innovative products for the bottom of the socioeconomic strata, government right from the beginning has been taking steps. And right now, we had a lot of experience because health, you may not know, is a state subject. So essentially, the cause of action lies with the state. And the center is only supposed to facilitate it or be the enabler of getting bigger initiatives through. So a lot of states, a lot of government organizations in the center and the state had been experimenting with small-scale insurance products for the poor. Learning from that experience, this scheme was launched in 2018, and it essentially covers bottom 40% of the population. We provide health assurance of 5 lakh rupees per family per year, irrespective of what your pre-existing conditions are or what the size of the family is. It also is a scheme which is portable. You know that that labor migrates from one state to the other. So like you must have heard of the One Nation, One Ration card. Similarly, this scheme is also portable. So if I am a laborer from Bihar or UP working in Gujarat or Karnataka or Kerala and I fall ill and I have this card, then I am assured free treatment in impaneled hospitals. These hospitals are both public and private. As of now, we have 28,000 hospitals who are impaneled under the scheme, out of which 12,000 are private hospitals and 16,000 are government hospitals. So under these, there are a lot of very, very prominent names who are a part of this scheme. We have 33 states and union territories participating in the scheme. 3 states are not participating because they have some independent scheme which they are running, which is Odisha, West Bengal, and Delhi. The other states are all participating. It's essentially a sponsored scheme, so we pay 60% of the expenditure, and the rest 40% is given by the state. There is complete flexibility to the states on how they want to run the scheme. So about 24 states do it on an assurance model. In a sense, there is no insurance, and whatever is the expenditure, the government bears it. There are 6 states which do an insurance model, and some of you may be working with those states, like Rajasthan is there, Gujarat is there, Tamil Nadu is there. So these states, they have an insurance a model where they pay insurance and then take it when the expenditure happens, the insurance company pays for it. And there are 3 states which do a hybrid model, where till a certain limit it's covered by insurance, and after that the state government bears the share. So you would appreciate that in a country like India, there is no one size fits all and there's no one single silver bullet, right? The only single silver bullet is that we have to look after these people. So we've given complete flexibility to the states, and they can do whatever suits their interests best. It has both rural and urban coverage, and it's a comprehensive coverage. So we cover about, over a period of time, with the help of experts, health experts, and people, organizations who are working with health problems of the poor, we have identified about 1949 packages, and they cut across 27 specialities. Now, so the unique part of the scheme is that they're not standalone items of treatment which you're doing. So a particular disease and a particular condition gets covered through a bundle of, it's a bundle of services which you're providing, which includes diagnostics, includes medicines, includes the entire medical chain. And you'd be happy to note that recently we've also included really high-end stuff which nobody could even have imagined, that we're looking at even organ transplant. So kidney transplants, bone marrow transplants. Can you imagine the health security which a poor person gets if he knows that his kidney transplant is covered and he doesn't have to pay a single penny? We've also included mental disorders. So the packages are constantly being reviewed, revised. We also have a window where we accept suggestions coming from the medical tech sector or medical devices sector, where you can have some really new diagnostics procedure or machine coming up. And we invite those people to come and give presentations, and if we find value for money, which all of you understand the concept, then we include it as a part of our package. So we're constantly evolving, we're constantly on our feet, and here also we have given flexibility to the states. Suppose a state has a specific disease which is not covered in other states, like sickle cell. It's very, very specific to certain areas of India. So those packages can be customized differently. So the whole purpose of the scheme is to look at giving health and economic security, keeping in mind the local conditions. And why am I saying economic security? Because you all understand this, that if you are getting access to health services in time, not only do you prevent your condition from getting worse, but it improves your productive potential, because that means less days of wages lost. It means faster recovery. So you're able to contribute much better. And we know that 97 or 98% of our people work in the informal sector. And since we're essentially looking at the informal sector, in a major way, we're contributing to the economic growth of the nation. It also helps in improving and the health-seeking behavior of the people, because once you know that you're covered and you'll get access, then you will go out and get those health services. Of course, it's not easy. It has taken us a lot of time to build up the system, and because the system is so huge and it covers so many different kinds of conditions, we have it's entirely based on an IT system which is extremely robust and interoperable. For example, you would never imagine, all of you know about Aadhaar, right? So, and you know about UPI. So we have been building on these digital public goods which the country has been developing over a period of time. And we have a very, very stringent protocol for the entire process, right from identification of the beneficiary to when he's treated, and then when he's also discharged from the hospital. So everything is based on an eKYC. So the card also is made after an eKYC. When you go to a hospital, you have to have an eKYC. When you get out also, you have to have an eKYC. So we're trying to, because in such a big scheme, there are bound to be leakages, there are bound to be loopholes. So how can we plug them best? Hence, this IT platform and leveraging the digital public goods which have already been created, the system has been created. It's completely cashless and paperless. So anybody can just walk into an empaneled hospital and say, even if he doesn't have a card, he can go give his Aadhaar number. They can search whether the person is a part of the identified list. You may have a question of who are these people? Who are these beneficiaries? So there was a socioeconomic caste census in 2011, where on the basis of certain socio and residential, and for the urban areas, it was basically occupational criteria, they identified some poor families. So when the scheme was launched, this list was already dated, and it wasn't a very accurate list. So we gave the flexibility to the states to substitute the number which was fixed for a particular state. You could substitute the families which you could not identify with people matching the similar socioeconomic criteria. So you have heard of the ration, where we give free ration to the bottom 60% of the population. So a lot of states have actually substituted the unidentified families with the ration card families. So there's a lot of overlap between the two, and everybody knows who's entitled to 2 rupees ration or free ration. So they know they're eligible to that extent. People are aware of it, and they can get access to these services. We also monitor the quality of the health which we are giving. So we have special incentives for those hospitals who are NABH qualified, either at the entry level or fully certified. We also give incentives to the hospitals who are in metropolitan cities because their costs are higher, and also to those which are teaching hospitals. It's a very, very simple process. Some of you may have worked with the ISAs. The entire system, we're using the companies, or I would say, the processes which a typical insurance company would use. So we have TPAs, we have ISAs, who help us in the entire process of, pre-authorization, then claim adjudication, then claim approval, and then final payment. So the process remains the same. So we've learned a lot from that. I would like to say that this is actually a scheme which is completely transforming the entire health ecosystem, both in terms of the demand creation, also in terms of the supply side of it. Can you imagine? One would always think that the government and the private sector would be at odds with each other in terms of providing for healthcare services. But this is one scheme in which actually both of us are working together to give the best which we can. If you have 12,000 private hospitals who are empaneled under this scheme across the entire country, so you can imagine the participation. And one very important part is that we're not discriminating against the government hospitals. So whatever claim revenue is generated through a particular procedure, it goes equally to both the government and the private. So the government institutions, in fact, are using these funds to improve the services which they are delivering. They can give incentives to their own doctors, to their support staff, build infrastructure, and certain states have done a wonderful job of how to utilize this revenue. So I think it's a perfect example of how we are actually able to create the synergy between the government and the private sector. The standardization which we have done in terms of standardizing the packages and the costs also have an extremely important effect on the health ecosystem. The way the services are being delivered by the healthcare providers. And I think it would be a good point for all of you to actually have a look at some of the new things, new practices which health providers have developed on account of the scheme. I would also request at this stage that considering how we are actually expanding the health insurance, health assurance stroke insurance market, it would be a good idea for the health insurance companies to see where they can actually fit in terms of covering those people who we are not able to cover. Because there's a huge missing middle in the middle, which all of us are aware of, right? And being risk averse, The health insurance companies don't look at the poor, which we are looking after, but the economies of scale which we are generating, the good practices which we are generating, those can be leveraged by that health providers, and then you all can come up with some very innovative and some very good products for those people who you're not covering right now. Some of the mechanisms we set up for fraud detection or deterrence also are pretty good. We are using artificial intelligence and machine learning in a very big way. And this is not something which is going to happen, which is going to be static. It's something which is evolving every day for auto adjudication, for deep learning models, for looking at the disease pattern of the nation. So a lot of data is coming out of this. We will be sharing this data, keeping in mind data privacy guidelines with the entire ecosystem, so that you're able to use it to look at what the future holds for us and then come up with products, and which are reasonably priced, which people can afford. So this is something which I think has a major impact on the health ecosystem. Here I would like to mention the highway part of it, right? So since we also look after the digital mission, which is essentially we are trying to create the backbone for a digital digital health ecosystem. Since we already have Aadhaar and we have UPI and we have very mobile network penetration is very, very high. So we're leveraging this, and we have 4 core building blocks of the digital mission. The first is creation of a unique health identity for each individual. It's a 14-digit number. We can't do it with using Aadhaar, because all of you know the reasons. There are privacy concerns and other reasons behind it. And then we have registries for the health providers and the health facilities. And these are uniquely single source of truth, which is going to be done by the councils. Once you have these 3 things in place, then automatically, and we are creating the platform, the networks, where we are providing the interface between the health users and the health providers. And as a part of that, we are developing the National Health Claims Exchange, which I think is going to be a game changer. IRDAI has been collaborating with us. This is going to be launched, I think, very soon right now. And it's completely end-to-end. It's a paperless and an IT-based system, where right from identifying the person who's buying the insurance product to standardizing what information you want from him, the entire treatment, the pre-authorization, etc., which you all know about, the entire treatment cycle, and then the claims submission, and then the claims passing. It's going to be based on a completely digital system which everybody can access. So this product is absolutely ready, and hopefully we should be able to launch it in about 15-20 days. I think this will have a lot of rip-offs in terms of efficiencies, economies of scale. It'll be really, really phenomenal. And I would request you that you must get onboarded on it once it's launched. Finally, let me look at what I think, what my organization also feels are areas of collaboration between the actuaries and NHA. I'm happy to share with you that we've already signed an MOU with the Institute of Actuaries, where we're looking at how we can use your expertise to help us make better financial projections. As you understand that we haven't made any discrimination between, we do no gatekeeping, so to say, and the disease burden is higher in the lower section, surprisingly, which was a surprise to most of us when we realized that we used to think that diabetes and health and cancer was not as they're all lifestyle diseases and not as prevalent in the lower economic strata, but we found to our surprise that's not the case. So obviously, what we need to look at is how we will look at the financials of the scheme as we want to either run it better, reduce leakages, and also if we think of expansion. And what are the kind of things we can look at that. So that is a possible area of collaboration which we are looking forward to. Also, we would like to work with you in also looking at what are the various models or what are the various products which can come up for providing health insurance to people who can afford to pay for it. And by that, I don't mean the extremely 2% of our population. I mean the 60 to 70% of our population who's in the middle. So that's something also which we can look at. You can definitely look at our practices, our fraud deterrence, our standardized treatment guidelines, our rationalizations, and see how you can use that to push efficiencies within your sector. I'm not saying that there would be efficiencies, but definitely that's something which if you can look at and do a third-party, completely neutral analysis of it, it will help us also in seeing whether what we are thinking, how we are evaluating the scheme, is it similar to what you are saying or not. So this is in terms of what my expectations or what I look forward to in terms of our future collaboration. And I hope that post this conference, we can actually sit down and frame out and come up with some certain concrete deliverables which we can actually provide in the next 6 to 7 months going forward. Thank you so much for your patience and your patient hearing. Thank you so much. Jai Hind.
Thank you, madam. I think it's, you just covered the whole scheme in the span of 15, 20 minutes. I think for some of our audience, I think madam has been very modest in terms of, just telling the whole size of the scheme. I mean, the scheme membership is actually larger than the population of certain countries. I'll give you some numbers to really astonishing numbers. And we as a CEO, and the true CEO of probably the largest number of health beneficiaries you will be managing, madam. I think it's sheer the numbers is astonishing. I'll just give some numbers for our audience. If you look at the scheme was actually, this NHA was started on the 2nd of Jan 2019. And the number of Ayushman Bharat card issued since then, 306 million. Guys, 306 million. Yeah, 310 million I was saying. It's amazing. And in 24 hours, how many cards get issued? 118,000 cards in 24 hours. 118,000. 1.2 lakh. Amazing numbers. A number of hospitalizations since the inception. 62.8 million hospitalizations. It's amazing number. I think it's really hats off to you, madam, for managing such a large, huge scheme. I mean, I was looking at the populations of UK, France, some of the European countries. I think it's just covering half of the whole Europe. So amazing. Actually, we've really privileged to have madam here. I think madam has all her career has been associated with, most of the, the poor society of the country in terms of rural population, urban poverty, urban infrastructure, poverty, and the housing for poor people, and education. I think so. We're privileged to have her. So I would actually just ask. I think you covered a little bit of that. Given the sheer size of the scheme that you're managing, and so many state health agencies, and dealing with so many SHAs, you mentioned 32 states. What sort of challenges do you face in managing such a large, the customer base, or even the people actually who are managing this whole scheme implementation? What sort of challenges do you face?
Thank you for your kind comments and your confidence in National Health Authority. So I think the foremost challenge is actually getting people to be aware that they are entitled to this scheme. This is an entitlement-based scheme, so anybody who's a part of that targeted population is entitled for the scheme. But just getting the message across to them that they have the right to claim benefits is a major challenge. So we've been using multiple ways of getting the messaging across, because you must have, all of you have people who are working with you, you're doing domestic either in your houses or when you're doing informal kind of thing. For them, even that 1 or 3 hours which they are missing out of their labor actually affects their financials. So for them to understand, no, you have to see whether you are entitled and then get a card made, and when you fall ill, please go to the hospital and you will be taken care of, is very important. They'll say, dekha jayega. Whenever we fall ill, we'll consider it. But we realized that initially when we started the scheme, we thought that everybody will know that they're entitled and they will go and access. Then we realized people didn't know about it. So then we started issuing these Ayushman cards. So when you give somebody a card, he becomes empowered and he becomes aware that he is entitled to that service. Like for example, I went to a very remote village in Mandla, where the entire village migrates to Gujarat. They go there. One goes to Kerala to do, I think, cardamom plucking or something, and the rest moves to Gujarat. And they had no idea that they are covered. They had the card and yet they did not know that they were covered. So, it's a constant messaging which we have to keep on telling them ki aapke paas, you have a card. This card means that if you fall ill and you're hospitalized, then if you're hospitalized, 15 days of hospitalization, your drugs, diet, everything will be covered. This is a huge thing. And the second is getting hospitals to understand how to, to operate under the scheme. Both government and private, because they haven't handled this kind of heavy documentation, procedures, that is a big challenge. And we're still working at it. I won't say it's complete. And that is why we constantly need to keep on evolving. And that is why the digital IT system is very important. Digital health in our country, the penetration is extremely poor. Even the best of hospital chains hardly maintain electronic health records of their patients. Or if they have them, they don't share them. So under the digital mission, that's exactly what we're trying to do.
Thank you, madam. I think one other question, that interesting question that I have, which was just, so I think we're dealing with the most vulnerable societies, and these people, when they see there's some free treatment is being given, right? They don't believe it. It's like, oh, you're going to the hospital, you won't be charged anything, and you'll get the treatment. And you give the example of even some of the organ transplantation without any cost happened. And given that, these customers will probably do not have high expectations, if you look at it, because saying you're not being charged, you will be treated. How do you ensure the quality of services that these guys get? Because, they themselves are not so aware of the quality and their rights. In fact, the government is providing a lot of facilities, but the whole awareness is quite low. How do you ensure that the quality of services which are being given to these, I'll call them customers, is of good quality?
That's also a very good question. So we have this call center which runs 24/7. Every patient who is discharged is given a call within 2 days of his discharge, and where we actually ask, there's a set of 7 or 10 questions which we ask the patient in terms of not only what kind of treatment was given to him, but we also ask him, did you pay anything? If you paid something, who did you pay it to? And what was it paid for? And then each of these grievances is again then followed up till we are able to ensure that that grievance is genuine or not genuine. The other thing is that we're also looking, although I told you that we're giving incentives to quality, because I said we're giving a higher incentive to those hospitals who are NABH certified. But slowly we're also looking at how we can move the focus from quantum of care to the quality of care. So there is a particular formulation which we have developed. It's being experimented in a certain pilots. And hopefully as we get more and more experience with running of the scheme, we will upscale that. So this is basically how we are looking at it. We also, when we do, like I said, it's a digital system. So we also have a feedback mechanism within the transaction management system where we take a feedback from the customer. I mean, at school you call him customer, so it is a customer, it's a client.
Yeah, exactly. So I think that's, this is amazing. I was just, we all, in the insurance companies, we don't have such a large database or such a large client base, if you call it. It's actually the client of all NHA. So just think about the mere size of getting the feedback from the customers. And, as Madam saying, within a day or two, try and connect with the customers and get the feedbacks. It's really, really amazing. Madam, just one question that I have. So you talked about that NHA actually has got, the states have got two set of models, which is got trust model, and the other is more of insurance model. There is also a hybrid model that you have. What has been your experience in terms of which of you found the best, the most optimal model? Is it trust? Is it insurance? And how could really insurance companies, because most of the people sitting here are from the insurance companies, maybe life, general, health, how could they really give better offering to the customers to align with the needs of NHA?
Like I said in the beginning, there is no single silver bullet and there is no perfect solution. So like every state has its own set of conditions. And we have done a lot of studies in seeing which is the better model, whether it's assurance model or insurance model or hybrid model, and the jury is still out. So we still are working at it. I think once now we have much more data, then maybe come up with a very, very, very specific recommendation. But there are strengths in both the systems. And I find that both of them have some very good practices which each can learn. Insurance companies, your gatekeeping mechanisms, the way the auditing takes place, those are some things which the state governments and assurance model learns. But the orientation in terms of passing the claims in a particular time, a TAT, then covering much more irrespective of what kind of conditions the person was coming from, or if there's something missing, that comes better in an assurance system. So both of them have their advantages and disadvantages. And your second part was regarding, sorry,
no, so what insurance company, how could they improve?
Yes.
Yeah.
So I think we are working with, see, our entire system, even the assurance model, we use the same model which you do. You have ISAs and you have TPAs, right? So we do the same thing. We also use ISAs and TPAs to do the entire cycle, like I said. I think now is the time has come for the insurance companies and the whole universe of people who are working in the health insurance side from each of the process chain to look at really good innovative products for those people who can afford to pay for it. And how do you price that? We have so much of data now, we have so much of experience now in terms of how hospitals are running, which are the pain points, what are the, where are the financial, savings which you can make, what is the leverage, what are the economies of scale which are going to come. Some very good pricing and good products can come in if the insurance companies come forward in that aspect. It's really important for us that now they come and look at this missing middle.
Yeah, thank you, madam. I think all our actuarial colleagues would really look at this. Thank you for that comment. We're running short of time, but we'll take few questions from the audience. If you can just raise your hand. Yeah, please. Jayesh bhai.
Yeah, am I audible? Yeah. So my question is like, as this is a very large scheme, so are there any chances of fraud by the hospitals or the people being exploited? So how big of a problem this is, and how are the institute trying to tackle this?
Yes, I think in any system, whether it is small or big, frauds happen, right? So we are prepared for that. But let me tell you, I'm very happy to share that the fraud as a percentage of total claims is extremely low. It's, I think, 0.3 or 0.4% as of now. And which is not to say that we are not, we haven't put in the best mechanisms. We've used AI, we've used very good triggers to audit the claims, pre-audit the claims. So this is definitely it's a challenge, and people are going to become smarter as things develop. So there is, I think, the more we digitize, the more we standardize, the chances of fraud is definitely going to be reduced. And simultaneously, this is the prevention and the deterrence part of it. So the penalties which we have set up in our system are pretty severe. They're very, very high. So it's just not de-empanelment, it's also a criminal action and a financial penalty. So that also we are pushing in a major way. we found that there were not only frauds, there were also malpractices. Like it is there in the health sector. We all know, we all have suffered. When you go to a hospital, you are obviously in certain places you are overcharged, or you are overdiagnosed, or you are prescribed those diagnoses which you don't require. That's a constant problem which the whole health industry is facing. It is not something which is specific to us. So hence, that is why I stressed on the standard treatment guidelines. You know, how we are actually, we keep on looking at the standard treatment guidelines and looking at how we can structure them in such a way that you reduce both the incentive to do a malpractice and also the instance to do the malpractice. So it's a constant, it's going to be a constant effort. There is no doubt about that.
And I think this eKYC and the
EKYC,
digitization
as
is
far as the
foolproof.
individual is concerned, that I think we have more or less fixed.
Yeah.
But in terms of the treatment which we are giving to the patient, and comes to the outcomes which have been coming. Like I said, I'll spend 1 minute on that. We're looking at how we can look at diagnosis-related groups, how we can look at the value of care in terms of the outcomes which are being delivered. So this has been, I think, internationally also, there are certain standard ways of measuring this. It could be, hospital readmission rate. It could be the out-of-pocket expenditure. It could be the grievances. It's also the quality of life, health-related. So there's a small index for this which we have developed and which we are experimenting with. And now that I think it has reached a certain level of maturity, we can afford to do it. Initially, we were just still struggling with setting up the system, which takes 2-3 years. I mean, you imagine the scales of it. So that's a huge issue.
Hello. Hello. Excuse me. Yeah, okay. Can I ask a question?
I'm okay. Whoever wants to ask a question.
Okay. Madam, I'm thankful for this presentation. I mean, really, you made us aware of such a thing exists, and so kudos to you. My question is that in diseases like cancer, which actually is a long drawn-out process, pretty expensive, where the person not only gets out and then gets into a checking mechanism for 5 years or something to declare cancer-free. So how does your scheme, the scheme covers, to what extent it covers that expenditure, because it can be drawn out for 2-3 years. That is one part. Secondly, prevention is better than cure. So bad health is a strain on the government funding on exchequer. So do you run awareness programs in schools and this thing? My personal opinion, that should be part of school curriculum. So do you do any such things? Thank you.
Thank you. So the first part, it's very simple. We have no cap in terms of, we only cover 5 years. Like I said, it's 5 lakh rupees per family per year. So the person is entitled to that level of treatment till he's declared cancer-free. It's not as if, it's only for it's for 5 years and again he has to go for a thing. So he's covered. Our 99.95% of our claims are actually less than 2 lakh rupees. So as of now, there is no challenge as far as that is concerned. Yes, I don't know, you people may not be aware of it, but the government is running a non-communicable disease prevention and awareness program through its other, I said the preventive part of it, the Ayushman Arogya Mandirs, where a lot of emphasis is being placed on the wellness aspect of it, the preventive aspect of it. It is in your lifestyle. So that is going on in tandem along with this. There's also school health program, the one you were mentioning. There's a school health program also which is being launched by the government, where there's going to be a medical checkup of each and every child studying in a school, and his health record will be maintained. It's already a part of the curriculum. If you have seen the CBSE books, I don't know about the ICSE, I definitely know about the CBSE. The CBSE books has it at the appropriate stage, in the appropriate way. They have included things on, preventive health aspects. And the rest, we as citizens need to do. I think COVID brought out the importance of physical health and its interrelationship with mental health. In this we are deluged and we are completely submerged with the digital devices, and we spend our time completely in that. I mean, I'm sure a lot of people here also would be addicted to it. So to expect a child to leave his mobile aside and then go and play in the field, we as parents, we as relatives, we have a lot to do with that. So that's something I think we as a society should be working on. That's not something which the government alone can do. All of us as citizens have that responsibility, that we have to get up and look after ourselves and let our children look after themselves. Let them play in the field, let them go out. That's a complete, I mean, all of us have lived in colonies. I mean, at least in my generation, we used to play in the evenings.
Yeah.
वो 4 से 5 बजे, my mother would never let me sit at home. She would say, go and play, Baba. And now you're pushing the children. Ki, please, please, go and play. So there's nothing like a good sweating in the field. And I mean, people who are young here, this is just from a person who's growing old, to the youngsters here, you know, we tend to protect the children so much. He's going in dirt, he's going to fall ill, he's going to do this. No, Baba, his immunity is getting built up. The more he's going into the sand, the more he's going into the soil, the more he's playing, or he or she is playing, the more the child is getting immune. They must learn. That is my personal experience. That's nothing to do with the NHA or CA, but it's something which I think is borne by experience.
Yeah, thank you, madam. That is a very useful message. I don't think we have any, Jayesh bhai, we'll actually have separate interaction.
Yeah, he's been standing for very long, so I
Okay,
think he
yeah,
needs
okay.
to get that opportunity.
I'm from the consulting world, so the data would be available to the public, or like, see, we get many queries for a self-help group or any, so for the insurance company, the data would be available, but the NHA data, whether it would be available for consultants or it's publicly available?
So we have a data sharing policy, data sharing guidelines, which is on our website. We are looking at how we can best operationalize it, keeping in mind the DPDP Act and our own guidelines. So we'll definitely be making data available to the everybody at large. It could be insurance, it could be public health specialist, research, but taking adequate safeguards.
Yeah, right.
So we'll be anonymizing it, de-identifying it. We'll be doing that.
And second, just a second, like ABBA card or NHA would be, because of the large number, the cost would be lower. So anyone who is able to pay can pay and join NHA.
That's $1 million question.
So that would solve many problems.
I know. Easier said than done.
Sunil.
Okay, so, okay, Anil.
One
Okay,
last
one last
question.
question.
One last question.
So, thank you, ma'am. So there are, I think, quite a few problems. I could notice that. Like, one is the awareness is still a challenge. I think large population are still not very much aware of that this kind of a scheme exists. And coverage, I think, would still be less than 50%, though everyone need that kind of a coverage. So my question is that, as a government, so it's still a partnership between central government and state government. There's no participation from industry and experts, I think you were saying. And going forward, we would need to spread it to everyone. We need some innovative products. And maybe it has been started as a social security scheme, but going forward, if it has to be really part of the need that everyone has to have this kind of things that has to be commercially viable. So do you have any plan that someday industry will also participate into that, and you playing a role of facilitator, providing data, setting protocols, so a lot of other facilitation, and then let industry take over it, and it will have a multiple benefit. You will have a innovative products, and industry has such a large distribution force. They can use it and spread it across. But you rightly mentioned that I think somewhere you have got perception that we start things with saying no. But unfortunately, I think we have to look at data, and basis that then we have to decide. And maybe I think somewhere concern is that the kind of experience comes from certain state of the society, something needed at a price point doesn't work. So then it start with no and then we go down. And so in that situations, like if there is something that industry wants to do or you expect industry to do, have some kind of a scheme where any losses being incurred by the industry is financed by the government rather than government running these schemes itself. So just your thought on that, yeah.
Okay. So let me reverse the problem statement, so to say. If the industry had done something for the bottom 40%, government would not have to step in. Okay? So let's first understand that there is a gap. Okay? The private insurance industry doesn't find fair enough. Find it risk-proof to enter into this particular strata of population. If the industry, like I said right in the beginning, if you can come up with some really innovative product, something which is reasonably priced, which the poor can afford, then I think we have created that kind of demand with the poor that they can appreciate that. And if there's value for money, they may go for a supplemental insurance to claim those additional benefits which you are proposing to give them through a product, right? As of now, I don't think that there is a person, I mean, there's an industry or there are industry people within the private insurance industry who have the stomach for handling so much of risk and so much of population, right? Going forward, maybe, maybe not, I don't know. Probably it should be. However, I would like to urge you that the data which we are sharing, some of it is already on our dashboards. You can please have a look at our dashboards of both PMJY and Setu and see what kind of data we are coming up with. But why don't you look at the class which is immediately above the 40%? Somebody who's earning 15 to 20,000 rupees a month. The persons we are looking at are all those people who are earning between 6 to 10,000 a month, or maybe not even earning. Huge families, right? But people who are in that EPFO wala bracket, 15,000 se leke, say probably 25,000 rupees a month. Look at some products there. After all, the bulk of the people are there. And in that, if you need some help in terms of, looking at data or looking at something else, I'm sure we can find a way out. Without, in any way, going against what the DPDP Act and our own data privacy guidelines say. I have no qualms about that. So I absolutely encourage you to do that. And if there's something with the institute can do along with us, we would be more than happy to help you out with that. Definitely.
Thank you, madam. I think just to summarize, and just on Anil's point, there is plenty of opportunities. I think the Indian population is heavily underinsured, be it life, be it health, be it GI actually. So I think it's heavily underinsured and there's opportunities everywhere. And this, I think this strata, which is above the 40%, 41 to 100%, there's plenty of opportunities, madam. And I think, me actually have represented, industry, been there. So I think some, the kind of infrastructure that, your organization has created is amazing. And if we can, if the insurance industry can also take an advantage of those infrastructure, I think it would be a wonderful model wherein the whole cost of the service provider will get optimized and the insurance industry will be able to come up with more optimal products to meet the need of these customers.
Yeah, I'll end with what you're saying, and absolutely I'll second it or third it or whatever you want. Once the NCHX gets on board, and you all come on board, you will realize the importance of what we have created and how it can actually help you. So actually we're helping you do your business better. Hopefully, fingers crossed, that should be launched in the very next maybe 2-3 weeks. And I would request you to please come on board that platform.
Thank you,
use
madam.
that platform.
Thank you. So with this, we end the session. Thank you very much for being very good audience. And thank you, madam.
Thank you for such a thought-provoking session. Can I please invite Mr. Pankaj Kumar Tiwari, GM Health Department, IDA, to give a small token of thanks to our speaker and our chair.